Good morning, good afternoon, or good evening, wherever you are joining us from in the world. I want to thank you for joining us and welcome you to the 15th episode of FIP's digital program on the development goals, setting goals for the decade ahead. Today's episode is about Development Goal 12, Pharmacy Intelligence, unlocking the power of data intelligence for pharmacy. It's becoming a reality and will deliver real-time actionable intelligence. We're excited about the topic. My name is Robert Sindelar, and I have the honor of serving as the host for today. I also have the honor of serving as the chair of the One FIP Data and Intelligence Commission. As you'll see from the announcements, before we begin, do want to share a few things with you. First of all, the webinar is being recorded and live streamed via YouTube. The recording will be available on the website, www.fip.org. Please do share with your colleagues for those that may have missed the session today, so they have a chance to take a look. It is an important topic. If you have any questions as we go along, and particularly when we get into the panel discussion, please do use the question and answer function that you have on your screen. And also, if you are not a member of FIP, please seriously consider information about membership is there. So thank you very much for that. If I might have the next slide, please. So setting goals for the decade ahead. Let's begin, and we'll briefly introduce for you the program today. Next slide, please. So again, titled Setting Goals for the Decade Ahead is FIP's 2021 digital program on the FIP Development Goals. It's a comprehensive online event series which provides coverage over the 21 goals over 21 events. The main aim of the 21 digital events is to mobilize global pharmacy development and to transform pharmacy together through the development goals. By engaging our profession and members and colleagues everywhere, we aim to provide a description, direction, and context for each of the specific development goals. Monitoring and evaluating through data science and identifying priorities across practice, science, workforce, and education is also part of the program. The next slide, please, Chris. Okay, so the 21 events have really run between March and they'll run through December of this year with an average of about 2 a month, as you see, but September is special. We have a number of different events during September, and that coincides with the World Pharmacy Week and World Pharmacy Day. You can pre-register all the remaining events by visiting events.fip.org, and we encourage you to do so. We look forward to having you at any of the upcoming events over the next few months. So next slide, please. If I may, I'd like to introduce initially our 4 topic speakers. Today, we'll have 4 speakers that will speak to specific topics. They're Chris John, Antonio Rodriguez, Farah Akwi, and Shirley Liante. We will also have, as you'll see in the next slide, please, around those topics, we're going to have 4 case study speakers. The speakers are from Montenegro, Dr. Mira Zugic, India, Dr. Rao Vlad Lamundi, and Indonesia, Mr. Nurul Falah Edi Pirang. And they'll represent their associations in the countries and give case studies, really sort of the what's happening right there on the ground. And then we'll have a panel discussion. Okay, we'll also, Professor Ian Bates will come and talk a little bit about indicator activity, and I'll do a close. If I may have the next slide, please. We do have a few goals for the meeting today, and we will do our best to try and meet those goals. That's to define pharmacy intelligence and explain the priorities for its development for the FIP Development Goal 12, to list ways that pharmacy intelligence can enable healthcare, to discuss approaches to monitoring progress to universal health coverage, to explain the METNA project and its approach to data collection and needs assessment, document national case studies focusing on Development Goal 12, and describe the functionality of the GPO Atlas. So we're quite excited about today. Next slide, please. Before we hear from our speakers, we want to quickly remind you that the FIP Development Goals. The development goals were launched in September 2020 as the one FIP goals that bring together pharmaceutical science, pharmaceutical practice, workforce, and education. These were goals we developed together and helped to create. As per our vision and mission, FIP believes that we can have no pharmaceutical care without a pharmaceutical workforce, and we can have no pharmaceutical care without a scientific foundation for the next decade. Next slide, please. The FIP development goals are 21 goals that build on the 13 original workforce development goals launched in 2006 at the FIP Nanjing Global Conference on Pharmacy and Pharmacy Education. FIP used the same consensus-based approach to expand those goals into a set of 21, each reflecting elements of practice, science, and workforce and education. So let's watch a short video to see the 21 goals in action. Well, I hope you enjoyed the video. I am pleased to introduce our first topical speaker today, who is Mr. Christopher John. Chris is the FIP lead for data and intelligence, and also the secretary of the One FIP Data Intelligence Commission. Chris will speak today on the development goal 12, Pharmacy Intelligence Enabling Healthcare. Chris, take her away.
Thanks, Bob, and hello, everyone. Today, I'm going to be focusing in on development goal 12, pharmacy intelligence, and how it enables healthcare. I'll be particularly talking about the role of the Global Pharmaceutical Observatory, and we'll have some other presentations throughout this today from my colleagues who work on the Global Pharmaceutical Observatory as well, which I will signpost to in this presentation. So the Global Pharmaceutical Observatory is the engine room of Development Goal 12, and to show you a bit more about it, here's a video.
The International Pharmaceutical Federation is a global leadership body for pharmacists and pharmaceutical scientists. FIP collates data from our member organizations through surveys and other means. This data combines to form a broad scope of global data, and here at FIP, we create a global picture of pharmaceutical science, practice, and education. The Global Pharmaceutical Observatory provides global intelligence for our profession. The vision of the FIP GPO is to provide an accessible window on the work and trends of the global pharmaceutical community for all of our members. This means ensuring that the mission of the FIP GPO is directly linked with the vision and mission of of the FIP Global Development Goals. The FIP Development Goals will need monitoring and evaluation to ensure global progress. This cannot be done without a data-driven engine that is primarily focused on supporting and providing intelligence to members about the progress of these goals. It's a one FIP partnership model. This evidence will inform policy and development. Comprehensive data and good intelligence is vital. The more we know, the better informed we can be.
The FIP Global Pharmaceutical Observatory's mission centres around data, intelligence, advocacy and reporting. The COVID-19 pandemic has brought into sharp focus the importance of data, and for data to provide us with evidence, and for evidence to provide us with intelligence. So our first task is always to collate valid global data on workforce, education, practice, and pharmaceutical science, and the key task indeed of Development Goal 12. We must undertake comprehensive analyses of collated data to provide accessible and useful information that is high quality, and this must all be communicated innovatively to promote to our member organisations and to promote their impact on health. The communication will often be via the FIP Atlas, which is our visualisation platform for displaying our intelligence across the globe. And my colleague Shirley will be doing a demonstration and talk through of the Atlas later on in today's event. Finally, we will provide evidence-based strategic information, reports, and guidance on the application of pharmaceutical science, policies, practices, and services. The FIP GPO's outputs and influences will be sharing and disseminating intelligence that informs policy formation and advocates for the profession. And we've done that recently with promoting and advocating the pharmacist's role in vaccination programs as one example. Other outputs and influences are country monitoring, reporting, and information comparisons. So these could be benchmarking for how many pharmacies there are, prescriptions, regulatory comparisons, and service comparisons. Research and analysis is another output, evaluation of trends to support action planning, and facilitating collaborative working and national and transnational networking, bringing nations and organisations together to deliver transformational projects. Other outputs are evidence generation for capacity building, a potential for linkages with other observatories such as the World Health Organization and Organization for Economic Cooperation and Development, and health systems strengthening by tracking progress against the development goal is another output and influence of the GPO. Our current work across the Global Pharmaceutical Observatory includes the METNA project, which is Multinational Education and Training Needs Assessment, and my colleague Farah will be talking about that shortly. I've mentioned the Atlas, our online visualization platform and its dashboards. We are also developing a GPO microsite, which is our strong website presence and will give a lot of information about what is going on with pharmacy intelligence across FIP and our global partners. And we're also building a database, which we have begun inputting a lot of data, and so far we've put in the current workforce data we have, but we are adding data on community pharmacy, hospital pharmacy, medicines distribution and supply, and other areas as well. Bob mentioned the Data and Intelligence Commission. That's another key area of work, and we are advised on our strategic direction by the One FIP Data and Intelligence Commission, who meets regularly to discuss the big ticket items that provide assurance and guidance on achieving the GPO vision and mission. And the key item we will be addressing in the next meeting will be a data strategy. Finally, we have an important project that aims to produce indicators that will measure and monitor progress towards all the development goals. And we have an activity for you later where we'll get your input on how development goal 12 should be measured. So I mentioned that the GPO is the engine room of development goal 12, and development goal 12 you could imagine is the train, the locomotive that we need to progress our journey towards. Development goal 12 is split into elements: workforce and education being one element, practice is another element, and science is another element. And I'll go through all of these briefly in turn. The workforce and education element we define within Development Goal 12 Pharmacy Intelligence as having a national strategy and corresponding actions to collate and share workforce data and workforce planning activities, including skill mixes, advanced and specialist practice and capacity. And without workforce intelligence data, there can be no strategic workforce development. So the mechanisms for doing that are an operational global pharmaceutical observatory, developing monitoring systems to identify workforce trends to enable decision-making on deployment and supply of pharmaceutical workforce, noting that time lags are often present in these activities. And ideally, this should be linked with stewardship and leadership for professional leadership bodies. And we have some case studies coming in this event that will highlight some work in this area. Within the workforce element of Development Goal 12 Pharmacy Intelligence, we have a workforce and education team. The global leads are Marcel Paquin, Kayoko Takeda, and Saja El Nahar. And we also have a Development Goal 12 Workforce Reference Guide. And this guide collates all information, evidence, and expertise from FIP to support our members with measuring progress, evaluation, implementation, and transformation processes. To access the full Workforce Reference Guide for DG 12, you can see there is a link on the screen on the right. Development Goal 12 Pharmacy Intelligence, the practice element is that a comprehensive national strategy to collate, share, and utilize intelligence on service provision, development, delivery, and needs to inform evidence-based pharmaceutical services development, policymaking, and funding decisions is present. So the mechanisms for that are to develop agreed frameworks for the provision of professional services that include clear definitions, requirements, and standards against what it becomes possible to assess service delivery and generate professional service intelligence, to develop and implement systems for collating data and gathering and processing evidence on service delivery and availability across all jurisdictions and populations at a country level, and to define and recognise at a country level a set of minimum indicators and metrics for service intelligence. And there's a lot of work underway to do that. Also to develop integrated databases for service delivery, workforce and science intelligence, and to develop mechanisms for the rigorous and transparent exchange and sharing of service intelligence with stakeholders, partners, and other professionals at local, national, and international level. Finally, to develop the capacity to utilize big data, and we hear that term a lot these days, generated in practice and in science. And my colleague Antonia will particularly be talking about data generated in practice in the next presentation. And also to perform horizon scanning, trends assessment, and predictions. So, for example, demographic evolution, health needs trends, pandemics, and other emergencies. Finally, the science element is about data-driven decision strategies to accelerate pharmaceutical research, development, manufacturing, and market approval of medical products in order to maximize clinical benefits for individual patients. So the mechanisms are to enable access to virtual hubs for information sharing and enhancement of collaborations, and to promote open science gathering of data and information to accelerate all aspects of pharmaceutical sciences as a means of enabling pharmaceutical research intelligence production. And we've seen with the vaccine developments in the last 18 months, how quickly the sharing of data and information has happened and how it is possible. So the big lesson from the pandemic has been that the importance of timely, reliable, actionable, and disaggregated data. Obviously, this requires strong country data and health information systems through collaboration between governments, ministries of health, national statistical offices, and registrar generals, to name but a few. It also requires engagement with the private sector, academia, non-profit organisations, and the scientific community to ensure data is accessible as a public good. And Dr. Tedros, the Director General of the World Health Organization, says that real-time quality data to track population health is critical for every country to improve health outcomes and eliminate health inequalities. And that WHO is committed to work with countries and partners to strengthen health information systems and to support data-driven policies and interventions. COVID-19 is not the first pandemic and likely will not be the last. In order to be better prepared, we must have better data. Data, I think we can say, saves lives. Data is needed to track progress with universal health coverage. Universal health coverage is firmly based on the 1948 WHO Constitution that declares health a fundamental human right and commits to ensuring the highest attainable level of health for all. Achieving universal health coverage is a global commitment and is a major component of reducing inequalities and fighting poverty worldwide. So WHO works with partners in supporting countries to develop and strengthen their health systems to advance and sustain universal health coverage around the world, which stresses not only the coverage of health services, but also how they are funded, managed, and delivered. All FIP development goals contribute to universal health coverage. And the contribution requires measuring and evaluation through the creation of development goal indicators. So if we can track progress against the development goals, we in turn are tracking progress against universal health coverage. And the GPO will track progress against the development goals by collating the data for these indicators. Globally, the WHO measures universal health coverage in populations by the UHC Service Coverage Index of tracer indicators that include reproductive, maternal, newborn and child health, infectious diseases, non-communicable diseases, service capacity and access. As you can see, the FIP development goals all map to the UHC Service Coverage Index, and the contribution of the FIP development goals to the universal health coverage requires measuring and evaluation, as I've mentioned, through the creation of our development goal indicators, which the GPO will track. So over the course of 2021, we have been developing indicators for each development goal with the help of attendees at these development goal events. And join us later in this event to take part in an activity that will help us develop the indicator for DG12. Just in my last few minutes, I just want to make the case for data and intelligence and what it can do for universal health coverage. I think there is still a reticence perhaps with data and maybe a feeling that it is the preserve of perhaps IT professionals or other people, but it has many uses and is vital, particularly for us in pharmacy. It improves effectiveness of services. We can use data to bring about truly person-centered care. It promotes patient safety, and this links to service improvement. The information we collect can also help improve everyone's safety. For example, adverse drug reaction reporting. We can ensure effectiveness of treatments, devices, and tech, and data-powered vital research helps us discover new treatments that have saved lives in communities across the world during the pandemic. We can support new models of care, particularly if we want to shift the model of care more towards self-care or care close to home, then data becomes a key asset to looking at patient outcomes or by harnessing available data means. It can enhance decision-making. Leaders in every community need up-to-date, sophisticated data to make decisions. It can contribute to policy development, and there is a very close link between DG12 and DG13, which is policy development, as data to develop policy and produce guidance and standards improvement and regulation is essential. It can support population health. Data helps us manage population health by understanding current health and care needs and predicting future ones. It can help make best use of healthcare resources. So that is a case for data intelligence, but what must we do? Just my final slide, we must collect the data first and foremost. We need to unleash the unlimited potential of data in health and care while maintaining the highest standards of privacy, ethics, and accountability. So we need to exhibit strong data governance and protection. And I think that engages people more with the data, hopefully, without being too bureaucratic. We need to encourage innovation, develop and or enhance our data skills and achieve interoperability of systems. I mentioned observatories all talking together. And we must advocate for people and patients. We are living in an infodemic as well as a pandemic where there is a deluge of information, but we can help make sense of data as pharmacists and pharmacy teams. And I know some people are, again, reticent about big data and artificial intelligence, but these are useful tools for harnessing by humans. Only humans can care. We will never lose the human face of pharmacy, no matter how digital we get. We will be at the forefront of pharmacy intelligence and help patients, public, healthcare professionals and policymakers to make sense of this increasingly complex world. So thank you very much for listening, and I'll hand you back to Bob.
Thank you very much, Chris, and thank you for really a wonderful overview, and that's a great way to start out today. There'll be an opportunity for you to ask Chris questions during the panel discussion, so I'll ask that you share your questions with us and Chris during that time. Our second topical speaker today is Antonio Rodriguez. He is the Executive Director of the Portuguese Association of Pharmacy, and he'll speak on data and intelligence in action, community pharmacy data collection. Antonio.
Thank you, Professor Robert Sindelar. Thank you. And I would like, obviously, to start by saying hi to everyone, and thanks for having me and for having the opportunity to share with you some of the projects that we have been working on, particularly regarding the value of the data that we can collect through community pharmacies and how this can support decision-making in healthcare, and with the ultimate goal of treating better our patients that we are dealing every day in our pharmacies. Can you go on, please? Oh, thanks, Christopher. So before we start, I would like to say just 2 or 3 considerations. When we look to the FIP Development Goal 12, we can find very interesting objectives, and one of these, and I would like to focus on this one today, is the development of the capacity to utilize big data generated in pharmacy practice to perform several activities, such as predictions in healthcare. And I would like to focus on this particular subject for the next 10 minutes of my presentation. Before that, I would like, obviously, to remind you that just a very basic concept. When a patient interacts with the healthcare system, the access, along with the professional expertise of the pharmacists at the community level, is a key factor to support the development of intelligence tools. In each dispense, and even between dispenses, using digital tools, we can passively or actively collect data to support the delivery of care to patients and populations. And let's take just a look on 2 brief examples, one in infectious disease and the other one in chronic disease. Thanks, Christopher. Oh, so this one is ICAR, and ICAR, it's a model for this, it's a surveillance model for infectious disease based on the community pharmacy data. Next slide, please, Chris. Thanks. So just a brief introductory note about this research line. Several studies suggest that community pharmacy sales can support the early detection of disease outbreaks, such as influenza. And this is because individuals tend to look for pharmaceutical advice and treatment of symptoms such as cough or fever before or even instead of seeking medical care. Next slide, please, Chris. Oh, thanks. So according to this context that I gave to you, for the development of this surveillance model, we adopted a two-step methodology. The first step was to use an algorithm and data mining techniques to identify which products allow us to better understand outbreaks in the community from the sellout sales of the community pharmacy. The second step is to apply an epidemiological model, which allows us to predict the beginning, the length, the peak, and the intensity of the outbreaks, in this case specifically in Portugal, because we use Portuguese data, but obviously this is can be applicable for other regions too. Next slide, please, Chris. So let's take a look at some results. Here we have a graph with the influence activity per week. And the community pharmacy data, the ICAR model, is the green line, and the black line is the gold standard model used by health authorities to monitor the flu activity. And this black line, this gold standard model, uses data collected at primary care facilities. So the epidemic threshold, the black line you can see there, is the level above which we are able to say that the flu season has started. So as you can see, at week 49, the ICAR model, the community pharmacy model, crossed the threshold, but nothing happens at that week, 49 week, with the gold standard model. 2 weeks later, as you can see, in 51 week, the gold standard model finally reached the threshold. And these 2 weeks of prediction, these 2 weeks in advance that we can give this information to the healthcare system, to the health authorities, and to all healthcare professionals, are of major importance when developing public health measures and healthcare management to counteract the impact of flu has on healthcare systems and populations' well-being. These 2 weeks in advance are also seen in the detection of the peak of the epidemic, as you can see, analyzing the epidemic curve. Next slide, please, Chris. Next one, thanks. So this model, as you can see in the map on the right, made the community pharmacy network as a leading surveillance network in Portugal. Because we use data for pharmacies all over the country, we are able to anticipate influenza activity in each county, as well as see the spread of the epidemic per day. That's what you can see with the different colors along the country during the season, the influenza season. Next slide, please. Okay, so as I told you, we hypothesized also to use this in different pandemics, in different epidemics in the community. So we have firstly developed the model for flu, for influenza epidemic, and then we hypothesized that the model would also be applicable to the COVID-19 outbreak. So we selected a set of OTC products used for COVID-19 symptoms, such as thermometers, OTC products, and so on. And can you just press again, Chris, please? Thanks. So, and then what we did was to analyze the correlation between these cells in green with the COVID-19 cases in black. And the study and the model showed high and statistically significant correlations between the community pharmacy cells of these dynamic baskets and COVID-19 cases, particularly during the first wave. Obviously, the pandemic led to a behavior change and limited access to the pharmacy, affecting the ability of the model to predict the following waves. However, it showed very interesting results, as you can see, and the ability to predict specifically in the first wave. And this may be very useful for future predictions of COVID-19 outbreaks, namely if the infection becomes endemic. Okay, so this is the first example I'd like to show you, and how with very, very simple data we can produce knowledge that is very important for the healthcare system, for all the healthcare profession, but particularly important for the patients and for their safety. The second project I would like to share with you is Follow. And Follow, which is this one, it's the community cohort that we are developing in Portugal. And this community cohort it's like an in-depth looking to the population. It's like trying to answer to the healthcare hot topics that are emerging nowadays, such as the relevance of real-world data and knowledge produced from real-world data, the need of developing value-driven healthcare systems and measuring value in healthcare, and also particularly important for us is the growing role of the community pharmacy as the research site, and the growing role also of the community pharmacists as a clinical research. So follow, it's defined like a continuous observation of the population from the pharmacy to the pharmacy. And I would like to, before going in depth on the application of this community cohort, I would like to share with you some methodological notes. We have started by recruiting patients at the community pharmacy. Can we go on, please, Chris? Next slide. Thanks. And after the patient recruitment, we were able to ambidextrously follow these patients, analyze retrospectively the adherence rate, persistence rate, and other medicine-related indicators. And next slide, please. And yeah, prospectively, we were able to assess, for example, we are already able to assess, for example, the effectiveness and safety issues regarding the health technologies. This is particularly important for health HTA, for health technology assessment. We are able to measure patient-reported outcomes and several other indicators. Next slide, please, Chris. So what we are doing nowadays is to recruit patients all over the country to develop a cohort representative of the Portuguese population. And the applications of a cohort like this one are several, but today I would like to focus on one example, which is the predicting event for chronic disease, as I told you in the beginning. But the application of collecting this data and assess the medicine-related indicators, but also disease-related indicators and outcomes that you can measure and that we are able to measure at the community pharmacy. We can do a lot of things like evidence generation, real-world effectiveness and safety evaluation, which is particularly important for HTA, the big data collection to support healthcare decision-making, and also measure value in healthcare, which is very important for a value-based healthcare system. And specifically regarding, give you just one example of what we are doing with the data that we are collecting through Follow, which is this community cohort. Next slide, please, Chris. Okay, thank you. Okay, so what we are doing already with this community cohort is to use very simple and very easy to collect data, like socio-demographic data, like age, BMI, or smoking status, some clinical data that can easily be collected at the community pharmacy, like disease-specific questionnaires or medication adherence. And using this very simple information, nowadays, with the knowledge that we already have, we are able to estimate in a population point of view, but also in an individual point of view, the odds, for example, of having an emergency visit in the next 6 months. And this is of huge value, because what you're saying here is that having some information, some baseline information about each specific patient that we are taking care of at the community pharmacy, we are able to predict future events. And by having that information, we are able to maybe to refer to their doctor, maybe to have some pharmaceutical intervention, maybe to have some medication management support to the patient, and so on and so on. So what we are saying here is that with very basic information that we can collect in the community pharmacy, we're able to predict future events and support pharmacist intervention. All of this with the aim to obviously increase or improve healthcare status of the population. And that's all. Thanks for your attention. I'll be very glad to participate and answer to your questions if you have. Thanks.
Thank you very much, Antonio. Again, we'll save the questions for the panel discussion, but we're looking forward to that. And when we get ready for the panel discussion, by all means, send the questions through the question and answer function that you have on your webpage. Our next speaker is topical speaker is Farah Akshad. She's the FIP Regional Engagement and Project Coordinator and she will speak on the FIP Multi-Educational and Training Needs Assessment, the METNA project. Looking forward to it. Farah, please.
Thank you, Robert. Good morning, good afternoon, and good evening, everyone. Today, I'll walk you through why we initiated the METNA project, the Multinational Education and Training Needs Assessment, FIP GPO METNA project, and the approach we use in the data collection and the needs assessment. So I'll start by explaining what is METNA in general. Chris previously presented a slide about the FIP Development Goals contribution to universal health coverage. And improving the quality of education and training has been identified as a key element for the sustainable development of the pharmaceutical workforce in achieving universal health coverage. And this is also an important component of the current FIP 2021 mission. It's also a priority area for a lot of countries and a lot of organizations around the globe. So as a result, the METNA project is our first global pilot of mapping education and workforce needs assessment using the FIP Development Goals as a framing device. The main aim of this project, as I mentioned, is to address multinational needs-based education for the pharmaceutical workforce in a cohort of nations across the globe and evaluate policy gaps on a regular basis. So we basically used this project to develop a comparative assessment in terms of priorities, needs, challenges, and to identify some of the national and some of the regional commonalities that are related to education and training. If we can go next, I would like to briefly introduce you to the project team. In addition to Professor Ian Bates, Christopher John, and Shirley Milaniti, who are with us today, we also have Diala Kodumani and Marwan Akil as part of the FIP Global Pharmaceutical Observatory team. We can go next. I'll now turn our attention to how we conducted this project, and I will give you a summary of the data collection process. This is just a summary slide. If we can go next. We started by inviting our first sample, which included 26 countries from different regions. And if we go next, you will see the first part of the data collection process, which is quantitative data, where we asked organizations to fill an online survey. And this online survey basically includes questions like workforce capacity, initial prioritization of the current national projects that are mapped to the FIP development goals. We've received responses from 21 countries and 26 different organizations. On the next slide, you will see the second part of the data collection process, the qualitative part, which included a short engagement interview and a meeting with each organization who submits the survey. And this was used as a validation and a clarification process to clarify on the data that we collected in the first stage and to probe further into the issues raised in the survey. In addition, we discussed specific needs, specific priorities, and challenges that are again aligned to the FIP development goals. These interviews were conducted with the support of national and regional liaison officers based on a pro forma topic guide. In addition to that, comms and tools were translated to different languages, which include Arabic, Chinese, French, Japanese, Portuguese, and Spanish. Interviews were also conducted in these different languages, and the regional and the national liaisons supported us in communications. We have 21 countries, 24 member organizations that have been interviewed. If we can go next. After conducting these interviews, we shared the findings summary with the organization to verify again the data with the member organization and to move forward with the analysis. Currently, we're conducting the quantitative and the qualitative analysis, and the findings will be released in a report soon. We will focus on regional educational needs, as well as aligning, as we mentioned, similar needs and priorities related to education and training. On the screen, you will see the statistics that I mentioned previously. And if we can go next, I will conclude by providing an executive summary of some of the key messages and findings thus far. So regarding the ongoing policies and programs, we found that patient safety, people-centered care, and competency development are, for most organizations, the main areas of activity. However, these are underdeveloped. For the interprofessional education and collaboration, the IPE and IPC, there is a need for pharmacists to be recognized by other healthcare professions. And this is linked to the IPE and the IPC practice. Regarding the metrics and intelligence, it is important here to mention and to highlight that pharmacy intelligence is lacking in most countries, and that this must be developed to support resolving educational and training gaps limitations. CPD and competency development. We found variations in CPD strategies delivery across the globe, as well as differences of CPD provisions. Regarding the workplace training and professional portfolios, those are uncommon, and this opens up opportunities to design programs that support this. Further development of competency-based education is required, especially for early career and advanced and specialist programs. In addition to that, the scope of practice is not usually defined for most of the organizations. Training gaps such as primary healthcare educational programs, for example, smoking cessations. We found a major gap in pharmacy technicians. Pharmacy technicians are a workforce segments that should be considered for workforce development, for example, in the primary healthcare, but there's a substantial training gap in the provision market, as I mentioned. And again, there's an obvious demand, an obvious gap for advanced and specialty training all around the world, like, for example, oncology pharmacy programs. So that basically concludes my presentation. Thank you, colleagues, and over to you, Robert.
Well, thank you very much. It was a wonderful presentation, and it was wonderful to really hear about the project and how well it's going. Thank you. Again, if there are any questions, we'll hold those toward the panel discussion, and you can submit those through the question and answer function. But now we're to an exciting part of the program, and that will be our case studies from around the world. Our first case study today, will be from Montenegro and be presented by Dr. Milanka Zergic. She's the president of the Pharmaceutical Chamber of Montenegro. Dr. Zergic.
Hello. Do you hear me?
Yes.
Of course. First, hello from Montenegro and greetings to all participants to this event. Maybe I will disappoint you because still we haven't so much data about these projects which we would like to do, because maybe you heard that we are in the top of the 5 countries because of our COVID infections, about mortality and morbidity, because we are a relatively small country, but we are in the top 5. It means that all our duties and all our plans, it's changed because and this time we don't have any strategy in collaboration with our authorities from government and Ministry of Health. Maybe it sounds unbelievable, but even few years ago, we don't have any answers at our requests, which are referred to our authorities. Maybe you know that we have our pharmaceutical law, which include the pharmaceutical care. We are so proud about it because we had so many plans which included in this about pharmaceutical care. It means temporary. We are working at asthma control service, and we include in this service and our colleagues from Institute from Drugs and Medical Devices, especially specialists of pharmacoeconomy, and we in the next days we expect to make a document with a relevant pharmacoeconomy analysis. This autumn, we also are going with the project follow-up with the patients with diabetes. And we expect in Pharmaceutical Chamber of Montenegro with those two projects and the analysis and data about those two projects, when we finish it, to sit at the table without authorities and make something like negotiations about our eventually third project, which will be managing in therapy. And the end of on the top one, maybe two on the list of number, because we are on the top one or maybe second in the list of COVID infections patients. Our society really need help for immunizations. Because of that, we are so sorry, and we are also worried because our authorities refused our helps. But we didn't give up, and still we don't give up. And we have a chance, and we have plans to go together with the Office of WHO to make some collaboration, and with help of their advice to go further and to make some negotiations about those advanced services, about our counseling and our advising about immunization. It means from this stage, I can maybe promise you, maybe next time, that we will present to you some data about those two services. It will be asthma, which is really good dates. And from the second one, it will be some data about this second service, which will be following up patients from diabetes. And maybe we hope so, then in maybe next month, we will come to some negotiations with our authorities and to make some agreement about our active immunizations pharmacist. Maybe I must apologize if you don't understand me in my English, but I hope that you understand our worries.
Great. Thank you so very much for your presentation. It was good to hear about what you're doing in Montenegro. Our second case study will be from India and presented by one of the leaders of the Indian Pharmacists Association, Dr. Rao Vadlamundi. Dr. Vadlamundi?
That's right. Thank you, Bob. Okay. When we are looking at the FIP Development Goal 12, there are three definite components in this, that is the workforce and education, and pharmacy practice and pharmaceutical science, and how things are exactly done, and what are the needs assessment, and whether do we have adequate number of pharmacists with the training required, etc. So we seriously wanted to look at the data that is available in India to see how much we can really understand what is exactly available in the country. Okay, and the data regarding workforce education, workforce distribution, etc., would tell us. May I have the next slide, please? Yeah, would give us understand pharmacy workforce requirement versus availability, level of competency needed, versus the existing. And that would help us to generate a plan or generate the workforce, train and deploy the technically competent pharmacy workforce to achieve India's healthcare objective. The data on country's pharmacy workforce requirement to meet healthcare needs also helps us to plan how exactly we can develop the academic capacities, that's goal number 1, and relevant competencies, that is goal number 5, and strategies for continuous development, continuous professional development to ensure that the pharmaceutical workforce is always trained and is competent and maintain the level of competency, and most importantly, to draft the necessary policies at nationwide. May I have the next slide, please? So what we did is we took a look at the current situation of data availability. What do we have in India as far as the data is concerned? We have data, very pretty accurate data on the availability of pharmacy institutions, and number of people are graduating each year. We also have data on number of pharmacies, which we also call medical stores, and we have how many number of pharmaceutical industries are there, and how many number of registered pharmacists are there, and what amount of pharmaceutical products are produced, the volume as well as the value for domestic and export market. All these data are available. Nevertheless, when we try to put these data together, certain information do not emerge. Data on how many pharmacies actually operate with pharmacists, what is the qualification of the pharmacist involved in dispensing medicines in pharmacies, whether the pharmacy is a hospital pharmacy associated with a hospital or a community pharmacy in an urban situation or in a rural situation, located in either an urban area or a rural area, and what are their qualifications? What kind of a remuneration do they get? And what kind of tasks they perform? And whether the qualifications comply or match the expectations or the tasks performed. What are the gender ratios? Whether there is equity or whether it is predominantly male, predominantly female. Employment trends of fresh graduates as they come out, they get registered, and how are they employed? Requirement versus availability, these data are not available. We can actually derive certain information from number of pharmacists available or graduating, total number of pharmacists available in the country, and total population. And we can say that there are about 1 pharmacist per 1,000 population. But if you go and then really look at pharmacists available to dispense, that particular ratio may not hold good. May I have the next slide, please? So there is a need to develop accurate, dependable data, as a part of the goal number 12, pharmacy intelligence, and that is the need to develop pharmacy intelligence regarding actual deployment of registered pharmacists in the country, initial information, and there is a proposal how we want to do it. The data has to be initially collected from selected regions, or from, we wanted to start at the educational institution level, and we want to identify the pharmaceutical institutes and placement cells. Each institute has a placement cell which actually tracks how the graduates, fresh graduates are employed. And then we can get information from different regions. How many employed in each category? In other words, are they practice-related jobs? The pharmacists are going to practice-related jobs. Are they going into teaching? Or are they studying further? Or are they in the industry-related services? How many are pursuing for further studies like a PhD or a master's program? And how many of them are in India, or how many of them are studying abroad in foreign soils? And how many are really actually getting registered? This data needs to be collected, because it's at a proposal state. May I have the next slide, please? From different regions, and then collate them together to get trends of employment in local community and hospital pharmacies. Are they going into service-oriented jobs? that information will be collected, collated, and as the current freshly graduated batches, you get information. Then you start digging deep and start getting data from 5 years before or 10 years, from today, not going forward, but go back and collect for the past 5 years and past 10 years and start compiling the data. So as we compile more and more data, and that's going to be a tough task to analyze it, but analyze it to get some trends, identify the trends that are coming from different regions within the country. And these trends would tell us how the pharmacists are deployed, into what kind of services they are deployed, and are these services what are expected and not expected, and if there are any course corrections or competency levels or service levels need to be changed, then we can make recommendations or advocacy such that policies can be generated. And from this particular data, we have more accurate information about how fresh pharmacists are registered, or deployed, And thank you very much. This is what we are planning to do. And then maybe in a 6 months time or 1 year time, we have some dependable data on this front. Thank you.
Rayal, thank you so very much for sharing what's happening in India. Our last case presentation will be from the president of the Indonesian Pharmacists Association, Mr. Nural Fala Edi Perang. And we'll speak really about an exciting project they're doing. Thank you.
Thank you, Professor Robert Sindelar. Good morning, good afternoon, and good evening, everyone. Thank you very much for inviting me to share our experience in pharmacy intelligence in Indonesia. We are currently implementing information system for pharmacists in Indonesia called SIAP. SIAP in Indonesian language mean ready. So today on behalf of Indonesian Pharmacists Association, I will share our experiences in implementing SIAP in Indonesia. This will be the outline of my presentation today. First, I will provide a bit of background about how IAI with their pillars adopting FIP DG Development Goals 12, Pharmacy Intelligence. Then I will share the development and benefit of our program SIAP. Next slide, please. In September 2020, the Pharmaceutical Workforce Development Goals were updated to 21 goals as a reference for developing pharmacies around the world. One of the Pharmaceutical Workforce Development Goals adopted by IAA is number 12, namely Pharmacy Intelligence. To create a professional organization, next slide, please. To create a professional organization and qualified pharmacists, IAI is based on 5 pillars, including responsible practice, organization quality, pharmacist branding, training for pharmacist candidate, and regulation quality. Next slide. Next, please. Now we will talk a bit about Indonesian Pharmacists Association, who is the professional leadership bodies of pharmacists in Indonesia. We are currently have over 90,000 pharmacists in Indonesia. We have a vision which is to support pharmacists who are able to directly, in an impactful way, improve health outcome for the Indonesian population. Similar to other countries, pharmacists in Indonesia are working in the variety of sectors, start from on raw material, next please, drug development, distribution, next, hospital and community, next. All of this related on how to ensure that all process across all these are quality assured by pharmacists. Next. Yes, next please. Yeah. The information system for pharmacists developed in Indonesia is called SIAP, or Pharmacist Information System. The beginning of the development of this application started from FG that was held in November of 2018. To gather information from some province, then pilot project in 4 provinces. And on April 2019, the Pharmacist Information System as an information system for pharmacists in Indonesia formally established in West Java, Indonesia. Next, please. The following is a SIAP dashboard display. There are approximately 70,000 applications for pharmacists needs such as recertification, mutation, member numbers, and so on. Users can also make an assessment for this application service. Next, please. Next. From the beginning of the FGD in 2018, the SIAP team made a roadmap for future application development. Hope in 2021 is fully implemented in 34 provinces in Indonesia in integration with government big data. Next, please. Yeah, the benefit of the application are divided into three aspects. The first for pharmacists is used for the portfolio of a pharmacist and personal data management. The second is for organization. This application can be used for IAA management system, information of pharmaceutical workforce in Indonesia, and also controlling of pharmaceutical practice professionally. Then the benefit for the nation is that it can contribute to the database for the national health workforce and description of tasks and distribution of pharmacists in Indonesia. Next, please. Another benefit of the application is as a media of learning CPD through webinars or video on demand, and pharmacists also can improve their knowledge and competence via online. Next, please. This is also an example of using the SIAP at the IAI annual scientific meeting activities. Next, please. Currently, the SIAP application has been integrated with the National Health Workforce Account, NHWA, system information that at the end link to the WHO Global Health Workforce Network data, National Health Professional Portfolio or CPORLIN, associated with the Ministry of Health and releasing online registered pharmacist certificate by Indonesian Commission for Health Workforce. And in the near future, SIAP to be integrated with Directorate General Higher Education, Ministry of Education and Culture, in getting information on graduate data for releasing professional competency certificate. National Identity Number from Director General Population and Civil Registration, Ministry of Home Affairs of IAI members. National Food and Drug Board for geotagging service facilities. Next, please. This is the customer satisfaction survey data in using SIAP. Most of them rate it as excellent, but of course, we still have to improve the performance and service of this application. Next, please. And this is the benefit of SIAP comprehensively. I adapted from Global Health Workforce. Number one is about available pharmacists. Number two is equitability distributed pharmacists. Number three is quality pharmacists. And the last one is performing pharmacists. And the last one, next please. This is the conclusion. The next please. From the explanation above, we can conclude that the application is ready to give benefit to pharmacists, IAI, and the nation. Then FIP Development Goals 12 can be accelerated by SIAP. SIAP can easily be developed based on current need. The last professional of pharmacists can be strengthened using the SIAP. Thank you very much.
Thank you very much, Nero. exciting presentation. Our last topical speaker will be Shirley Mailianti. Shirley will give a demonstration of the new FIP Atlas, really an exciting data tool for all that will be available to all of us. She is the FIP Data and Intelligence Specialist. So Shirley.
Thank you, Professor Bob. Good morning, good afternoon, and good evening, everyone. We have heard about the importance of data today and how it can be used to predict, for example, events in chronic diseases to improve healthcare system. Now, another question is, what would be the best way to visualize it? And this is where actually one of our current GPO actions and projects come in, which is Atlas Dashboard or online platform. FIP Atlas is our visualization platform for displaying our intelligence across the globe. It is a way for us to showcase our members' needs and priorities, which allow us to identify opportunities for advancing our profession. Currently, we have built some visualization in our Atlas for some projects that we are working on, such as the recent visualization that we presented in our regional meetings on the FIP member organization prioritization and provision survey. And another example also, another visualization that we presented during the council meeting, which is about the pandemic preparedness visualization. And today, I will showcase another visualization of our Atlas linking to today's event, which is about indicator related to FIP development goals, data, and intelligence. So we can play the video, and I will basically sharing about this platform. So this is how it looks like in the beginning, and we can see here basically it show about what data that we can show here, and we can basically choose the data based on FIP development goals, or we can also choose the data based on the metrics that we want to observe. Let's try first with the FIP development goals. So if we click on that link, we will see the icon of the FIP development goals. And let's say today we would like to observe number 12, which is pharmacy intelligence. So let's click on that link, and it will bring us to another page about what is the FIP development goals is about actually. So globally, we want to have a national strategy and actions to collect and share workforce data and workforce planning activities. And there we can see basically we can view some indicators. We can view number of pharmacies, we can view number of pharmacy technicians, number of community pharmacy, or we can also view the distribution of age of pharmacies. Let's try now with number of pharmacies. And it will show the global picture of how number of pharmacies or the density of pharmacies per 10,000 population look like. And we know this indicator is important because having an adequate, well-distributed and motivated health workforce, including pharmacies, is very important to achieve universal health coverage. So with this atlas, we can also see across region. And let's say now we would like to see in the Western Pacific region. And we can see there actually in Australia, the density is around 12.59 in 2016. And if we look at in 2012, it will be around 11.47. And we can also look at in 2009, we can see there the density and also the number of pharmacies. And we can also see the other country. For example, in here, we showcase Malta. And let's go back and try another indicator. And now we will look at the distribution of age, age distribution of pharmacies. And here you will see across country how the proportion of pharmacies is under 35, between 35 and 60, and over 60 looks like. And let's say now we would like to look at Africa. We have data currently from 5 countries. We have from Mauritius, for example, there, I think it's around 47. I couldn't see it clearly actually. So yeah, That's from Mauritius. And let's say in South Africa, we will see there 32% pharmacies aged between 35 and 60. And we can also see the other country. For example, in Madagascar, we see like they have active pharmacies quite a lot, and compared to the older and younger. And let's try now looking at the other region. Let's see with America, we can see here from 5 countries actually. And we can see, for example, in Costa Rica, they have smaller portion of aging, pharmacies over 60 compared to Argentina, who has like higher portion of pharmacies aging over 60. That's, for example, related to the distribution of pharmacies across age. And now we can look at another indicator, which is number of community pharmacy per 10,000 population. So with this, we know as well it is important to know the accessibility of community pharmacy in the population. And this is how we can showcase it. For example, we look at the Southeast Asia region now. You can see like the big bubble is basically they have more density compared to the smaller bubble. And you'll see here, if we compare in Southeast Asia region, we have India and Nepal who have more than Indonesia and Sri Lanka. And okay, let's try another indicator now, which is DG15, people-centered care. And here basically we would like to showcase the role of pharmacies, in providing services related to point of care testing. For example, in here, we collect the data about the blood sugar level, blood cholesterol level, blood pressure management, weight, height, body mass index, pregnancy test, and HIV test. And if, for example, we look at a country, let's say we look at Ireland, and we offer our text there, you will see what kinds of tests that community pharmacy provide in that specific country. So that's basically how it looks like, more or less. This is how our current Atlas platform looks like, and we are planning to hopefully to share this to our member organization, hopefully by the end of this year or beginning of next year. So everyone can be benefit by looking at and playing around with the Atlas later on. So I think that's all from me, Rob. I hope all of you find it useful. Bob, over back to you.
Well, thank you very much, Shirley. It's a great introduction to the Atlas, and we'll all be excited to get to really learn and to study and become more knowledgeable around it. An exciting tool. Our next part of the program will be a panel discussion, and it'll be more answering questions, and we have several already. And our topical speakers will be available, and if there are any other questions that may go out to the presenters from the countries, we'll ask them to go ahead and pop in. But if I might, how can we bring all these goals into effect, especially in underdeveloped countries? Tackling all of these odds. That's the first question. Anybody on the panel?
Sorry, Bob, was that about how we can use pharmacy intelligence to bring
Right, I believe that would be it. And the things that you had talked about as part of the development goals, 12.
I think it would go by nation. From my perspective, it would go by nation and what their priorities are. And Farah talked about the METNA project. And one of the things the METNA project did was identify each country's priorities as far as the development goals are concerned. And then you look at, well, what do you need to address those development goal priorities? And particularly with pharmacy intelligence, have you got the necessary infrastructure to get the data and intelligence you need to make policies, to inform plans, and to really have an idea of where you need to go and how you're going to get there?
Okay, very good. Anybody else? Any other thoughts about that? Okay. We have another question that's been submitted, and that is, what is the role of the Indonesia Pharmacists Association towards pharmacists whose STRA, the Pharmacist Registration Certificate, and Competency Certificates have expired to the large number of them?
Thank you so much for this question. First one, because in SIAP, we have a portfolio program. The three things, the first one is about portfolio of practice, portfolio of education or CPD, and the last one is about the social behavior. So in the SIAP, all of this is facilitated in the SIAP. So everyone pharmacist is in Indonesia is very, very easy to recertification by the SIAP. All of this is facilitated there. So no need to go to the office, to the branch of IAA in the province or in the municipal. Just everything in your gadget. That is the first one. The second one, if before you not practices or you have not competency certification, we facilitate with the exam. The exam have two methods. The first one is about computer-based tests, and another one is OSCE for the services, pharmaceutical services, like in community pharmacy, hospital, and the public primary healthcare. There are OSCE, objective structure clinical examination. But if you have in the industrial area or distribution area, the name of examination is OSPE, Objective Structure Pharmaceutical Examination. And that is also related to EC, yeah, 2 days examination. Thank you so much, Professor.
Thank you very much.
Sindelar.
Yeah. Next question. As we all know, data inconsistency is a major challenge for all data projects. Maybe Chris might be good to answer this. In your role as the lead for the data intelligence for FIP, how can our audience, our partners in this pharmacy intelligence effort, help solve the inconsistency of data problem?
It's a very good question, Bob. I think it's something we need to work in partnership with our member organizations about. We need to standardize formats, and that would deal with any inconsistencies around inconsistent formats, make sure fields are completed, try and move away from duplicated data and move away from multiple siloed systems. Try and make things as streamlined as possible. I think data inconsistencies lead to poor data quality. So we've got to try and make sure human error is kept out of it as far as we can, and that transfer errors don't happen. Otherwise, that can lead to inconsistencies as well, or unintended alterations. So I'm a big fan of trying to create databases that join up and that you've got everything standardized, because otherwise it becomes quite problematic, particularly circulating Excel spreadsheets and things like that. There's often inconsistent information. Also to use standard world measures, such as what the World Bank uses for income level of countries, etc. So everything being standardized is how I would approach it.
Great, great. Okay. What is the greatest challenge that worries you about developing a true world-class pharmacy intelligence culture? And I'll open that up to anybody if somebody wants to approach that. What is the greatest challenge that worries you about developing a true world-class pharmacy intelligence culture?
I'll jump in again, Bob. I would say national infrastructure and systems is vitally important, but you've also got to have a culture of pharmacy intelligence. And if you don't have that, it's very difficult. So you've got to have a very strong culture that sees data as an asset and not a problem. I see Professor Bates has got his hand up.
Ah, great.
Thank you.
Thank
Ian.
you. Yeah, thank you. Great question. Thanks for the introduction there, Chris, because I, of course, wholeheartedly agree with you on that. In addition, I would say trust. Our current FIP president is a keen fan of trust, trusting in ourselves, trusting in our member organizations. People won't provide data, whether it's already publicly available or not, unless they trust the person or the organization who's asking for that data. So building trust with member organizations in particular is a key element of our work at the GPO. We will never, ever cross ethical boundaries. We will never, ever publish commercially sensitive data. Why would we? But we will publish data cooperatively with our member organizations, because much of the data we've seen today, for example, illustrates how there is a global good in sharing data and making contrasting trends in data. And that will help all of us. We are in a data-driven world, but that's got to be managed by FIP in a way that generates trust between those who are providing the data. If we bring it all together and we share it out as a global database, then everybody benefits, in particular member organizations, because they can use this evidence to help negotiate or to discuss things with local government, national ministries, in order to get better funding and support for pharmaceutical services. And that in turn generates better healthcare for our patients. It's a virtuous circle if we get it right.
Okay. We'll take one, we have one last question from the audience, and because of our time frame, I'll have to go ahead and suggest that maybe that'll be the last. And if there are any other questions, please do just email, okay, our speakers, and we'll go ahead and try and answer that to you. But again, I apologize simply because of our shorter time frame. What is the plan of FIP about regularized remuneration or pay fixation of community pharmacists, retail pharmacy premises by convincing the local government? And this was a question from somebody in India. So it's about regularizing remuneration or pay community pharmacists.
We've had a global pharmacy report out, Bob, in the last few weeks, and what we'll do is we'll send that link out, because that has masses of information about remuneration and how that can be achieved. And FIP is always available to advocate on behalf of nations for that, but I would refer our honourable questioner to that report.
Fantastic. Very good. Okay, well, sorry for going ahead and having to move forward, but one always runs into that with these sorts of programs. Next, Professor Ian Bates is going to go ahead and provide some insight into monitoring and evaluating the Development Goal 12. Ian?
Thank you very much. I'll be very brief. This is an ongoing project. It will be an ongoing project for some time. Well, maybe even forever. Why we have goals, global development goals, is to help all of us to shape progress and to shape development. Goals are a direction of travel. We've been very careful indeed not to call them targets. We call them goals, because every country, every region has subtly different ways of moving forward with goals, but nonetheless, there is a commonality amongst all of them. We haven't come across any pushback at all from developing global goals as a way of systematically creating a framework for development across all those issues that matter to us. However, we do need to monitor progress. And we do need to find ways of measuring progress. And the Global Goal Indicator project is going to be an ongoing project that will develop a set of indicators, which is common to all of us across all nations, across all regions, so that we can chart and plot global progress on development across a wide range of goals. This is all about making systematic structures available so that we are not ad hoc anymore. We're not doing things, on a sort of random way, but we can be systematic in the way that we push forward our profession. So it's a big project that's going on, and we are at the moment looking at this on a goal by goal basis. I'm hoping the next slide will give us some, here we go. We'll keep this slide up for a little while. So we're having a bit of a focus on DG 12 today, as you can see. We've already done this brief exercise with 15 of our global development goals. And what we're asking you to do, all 150 of you on the call right now, is clock in, check in at that URL link just there. I think somebody's going to put it up on the chat box in the moment, or scan that QR code on screen, and you will go to a very short platform which will ask for your views on what are the critical indicators that will help us to monitor progress with pharmacy intelligence. Okay, what are the top line, the very top line critical indicators that you would like to see as part of the global dashboard for monitoring progress with this particular goal? There will be a follow-up message to all of you who have been on this call today. If you need a little bit more time for reflection, a short click, 5 minutes of your time, and we're gathering together all of these global responses to help us develop this global dashboard for monitoring progress periodically. So a long time, so that we can see how we are progressing. We are hoping, FIP is hoping to hold a ministerial congress, so a meeting of health and economic ministers in maybe next year, hopefully at the end of next year, beginning of the year after, details to be announced. But we would like to present to health ministers progress on pharmaceutical care, progress on pharmaceutical services, progress on primary healthcare, and the valid and critical role that pharmacists play, and in hospital practice and regulatory practice and all those other eclectic services we produce. So please do engage with this. It's 2 or 3 minutes of your time. It would be very, very valuable for us. Thank you, Bob, for allowing me that time.
Yeah, thank you very much, Ian. If you'd put that slide back up, and I'll go ahead and do a summary while that slide's up, just so that anybody needs the information, you have it. We encourage you to do that. First of all, it's always unfortunate that we never have enough time to come together, particularly in today's world, to meet all of the interest and questions and discussion that we want to do. But this is an exciting area, and I hope you stay engaged. And through the mechanism that Ian has described, there's a chance for you to really contribute to the success and changing the culture as we move forward. Second thing I'd like to mention is that episode 16, Working with Others, will be held around the development goal, and will be a parallel system to the event to this. Will be the 19th of October at the same time this was held. So I encourage you to consider going ahead and participating in that. If you want to register, it's at events.fip.org. The next thing is World Pharmacist Day, the 25th of September, which I believe is tomorrow. And please don't forget World Pharmacist Day. It's now the 11th year, and it's a real opportunity for our profession to make a vital role in improving health knowledge in every corner of the world. So I encourage you to participate, and you can go ahead and put up some information about that. And next slide, please. It only takes a few simple steps to create a graphic that you can add your voice to this event. And FIP has a link that you can do that. So go ahead on this page, take a moment and take a look at that link. And if you're interested, please do that. We encourage you to do that. All future FIP digital events can be registered at events.fip.org. So please do consider to keep on touch with the schedule and all the exciting events coming up, because there will be some in October, November, and December. So we look forward to that. I wish, if you would you all join me in thanking the speakers and presenters and case study presenters today? Wonderful presentations, very good. Great job, gang. Okay. I also want to thank each and every one of you, because whether it's the morning, the afternoon, or the evening for you in the world, it's somewhat special that we can come together to address in issues such as pharmacy intelligence and really start to move toward changing the culture. It's a matter of working together. Together, we can take data further. We can move data not really to just information or just really knowledge, but together we can really move data into the idea of being true pharmacy intelligence, to be able to be readily available, to be able to be visually easily displayed, and to really be actionable. I want to thank you very much for your time that you've given us, and I wish all of you a wonderful rest of your day wherever you are in the world. Thank you.